CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Thank you, Sean. Welcome, everyone. I'd like to acknowledge that myself, Aslam Anis, Director of the Center for Health Evaluation Outcome Sciences, I'm based here in Vancouver, the traditional ancestral territory of the Musqueam, the Squamish, and the Tsleil-Waututh Nations. And I would like to acknowledge their custodianship of this land for such a long time and hope that we can continue that in a good way. And I particularly would like to recognize the sad events that have transpired over the last week with the findings of the burial ground of 215 children with Kamloops. So we really do acknowledge we are in the land of ancestral lands of the First Nations, and also give our sincere sympathies and condolences for all the information that is coming out for the injustices that have occurred in the past. I would like to introduce Dr. Nathaniel Hawkins, who's an associate professor at UBC and holder of the Dr. Charles Kerr Distinguished Scholar in Heart Rhythm Management. He's an internal medicine physician who graduated from Edinburgh University before doing his PhD in medicine in heart failure at Glasgow University. It's a doctorate, I believe that would be a PhD. His studies included a randomized controlled trial using beta blocker, bisoprolol in pulmonary disease, and analysis from registries and landmark clinical trials. He moved to Liverpool for cardiology and fellowship training in device therapy. Concurrently completed a master's in public health focusing on epidemiology of cardiovascular disease, population modeling, and health systems. He's now an associate professor at UBC. He holds dual training and certification in heart function and heart rhythm management, providing an innovative perspective on integration of technology with chronic disease management. He is physician lead for the Regional Heart Failure Program at St. Paul's Hospital Heart Function Clinic and director of the Regional Heart Failure Audit. Most importantly, he's a scientist at the Center for Health Evaluation and Outcome Sciences. So I'd like to welcome Nat. He says his work is preliminary. He has lots of questions for the audience. So I hope we have an interactive session. Take it away, Nat.
Excellent. Thank you, Aslam. Yes, and as I'm saying, and I was saying earlier, this, the WHIP series was originally very much a work in progress, and I think this is, and as I was preparing for this, which is hopefully the intent, I think I generated more questions than I have answers for, but I'm hoping for lots of input from everybody here. These are my disclosures. I've had some grants and research support from Servier and Novartis, and speakers fees from Novartis and Boehringer. So I want to talk a little bit about sudden cardiac death and secondary prevention ICDs. I trained in devices and heart failure, and I have a particular interest in complex devices, so it's cardiac resynchronization and defibrillators, and then walk you through some analyses we're doing with Chris Fordyce and Brian Gruneau and all of the team at CHÉOS from the linked registries of a resuscitation outcomes consortium looking out of hospital cardiac arrest. And this is one which fits into a program that Chris Fordyce is leading, focusing on use and also trying to determine what patients are eligible for a defibrillator and what the barriers of care are to ICD implant and how that affects outcomes. So there's whenever sudden cardiac death and out-of-hospital cardiac arrest is discussed, there's lots of pyramids. So this is a very simple one, just to sort of ease you into things. But most of cardiac arrest and sudden cardiac death relates to coronary artery disease, most of which is probably undiagnosed at the time of the arrest. 10 to 15% of it relates to cardiomyopathies of various forms. And Cardiomyopathy literally just means cardio is heart, myo, muscle, and opathy pathology. That's how I explain it to patients. So you have a heart muscle disease. And then there's a number of electrical conditions just at the tip of the iceberg there, which also can predispose to it. This is a very classic paper, which was redone by Peter Noseworthy's group, but was originally described as Meyenberg's pyramids, which essentially you can see that, and this is one of the challenges for sudden death, is that there's a very high incidence in small populations. So if you have in the throes of an MI, you could have a risk of ventricular arrhythmia in the order of 20 to 30%. At the opposite end of that spectrum, there's a very low incidence in a very large population. So in the general population, the incidence is a couple of percent, but that's obviously a huge population. And then everything in between is sort of tiers of the size versus the risk. So I focus probably in this second tier from the top, which is patients with heart failure and reduced ejection fraction. And those are patients who merit the primary prevention ICD. Whereas we're going to focus today on the very top tier, which is a secondary prevention ICD for patients who have already had a ventricular arrhythmia. But of course, even though we're focusing on those top two tiers, the big challenge is we need to be able to predict, which is hopefully going to be another analysis within this program, trying to identify patients in those lower tiers who make up a larger overall population, who might be at risk for sudden death, and ways to pick those up. So I want to give you just a little flavor of what a ventricular arrhythmia is. So this is normal conduction of your heart for the sort of non-cardiology and non-medical scientists on the Zoom. You have a sort of starter motor, which is your sinus node in the atrium, the smaller chamber of the heart, that is made of cells that depolarize or fire off about once every second, 60 times a minute. It spreads through your atrium. It goes into a junction box between the atrium and the ventricle, the thick muscular chambers, and then that conducts down through your His-Purkinje system, through your myocardium. So that's on the left-hand side, and you can see on the right-hand side a little moving diagram of that. This is one of the mechanisms of cardiac arrest, and it's probably not a very pleasant thing to think of, but if you slice through your heart, it actually looks quite like a steak. It's probably about a centimeter thick. It's lots of red muscle fibers, and if you damage it, you'll see in the top left panel, you get scarring, which is that white tissue there. And scarring isn't homogeneous. It tends not to be one big dense area. It will have different areas with some viable tissue through it. If you move to the bottom left panel there, the mechanism of ventricular tachycardia, so a fast heart rate from the ventricle, is that depolarization I showed you on the last slide, as it goes through the ventricle and makes it contract, it hits the scar. Part of the charge starts to meander very slowly through the cracks in the scar. And when it comes out, the heart muscle has reset itself and is ready to go again. So then it re-enters the scar, and you get a circuit round and through the scar. What that means is your heart then contracts very rapidly. So that's the top right panel. It's an ECG of someone with ventricular tachycardia, or VT, with a very rapid heart rate. And the relevance of this is, on the bottom right panel, you'll see a moving image. This is a ventriculogram, so we're squirting contrast inside someone's left ventricle. At the start, there's a couple of full beats, and then it starts to do this sort of wiggling jelly-like movement. And that's because it's gone into VT, and you've got very rapid beats. The problem with that is your heart needs time to actually fill and squeeze, and fill and squeeze. So if you suddenly go from 60 beats a minute to 300 beats a minute, you literally are not pumping any blood around your body. So that's the mechanism of cardiac arrest tends to actually be very rapid heart rhythms rather than the heart stopping. And we treat that, or we prevent it with an ICD, or an implantable cardioverter defibrillator. This is, from an implant perspective, very similar to a pacemaker. All the veins in your arm turn into one large vein here in the top left panel that runs under your clavicle, your collarbone, straight down like a big road to the right side of your heart. We pass a lead or two down to those chambers. They've got tiny little screws that fixate them to the muscle. We connect it to a generator, which is quite easy. There's just a little ratchet screwdriver. They click in and we tuck it under a pocket. And then on the bottom right, you can see that on the X-ray. So there's the can up the top, and then the lead going in. And then on that lead, there's a couple of very bright bits. Usually we only have one of these bright bits. That's the coil that delivers the shock. And ICDs have a couple of amazing abilities. So the first is it can send little pulses called anti-tachycardia pacing, or ATP, into the heart in a very rapid sequence, and they will sort of wash over that scar circuit and set it back to normal. So that you can call the nice way. That's what I say to patients, and that's effective in 90% of the time. And that's why ICDs are fantastic. The second is, if that short burst of pacing fails, it will charge up and deliver you a high voltage shock. And that is undoubtedly a pretty painful and unpleasant experience, but it does save you from a cardiac arrest. So, you know, that's the tough way. So that's just an overview of ICDs. And there's two groups of therapy. One is primary prevention, which is to say, in that pyramid I showed you, we think you're at high risk of a ventricular arrhythmia, but have not yet sustained one. And we want to put in a preventative device. So that's primary prevention. And then there's secondary prevention devices. So that is patients who have already had a sudden death or an out of hospital cardiac arrest from ventricular fibrillation, VF or VT, and have presented to hospital and survived, and we want to protect them against future events. So there's something there that we think predisposes them, and we want to make sure it doesn't happen again. The key thing about secondary prevention ICDs is you only want to implant a defibrillator in a patient who you think is likely to have an event again in future. So if there was a cause that was, quote, reversible, then we would expect that patient's risk to not be high and they wouldn't need an ICD. And these were quite old trials. So back in the day, there was small randomized controlled trials of ICDs versus an antiarrhythmic drug called amiodarone for patients who've survived out of hospital arrest. So they were called AVID, CASH, and SIDS. And you can see by standards of today's trials, these are actually relatively small, so 500, 100, and 300 patients. And the criteria of these are subtly different. So it could be a resuscitated VF arrest, or VT with syncope, i.e. VT that's fast enough to make your blood pressure drop, or VT and another high-risk feature like your left ventricular ejection fraction, or you have reduced pump function of your heart. So it's already some scarring that predisposes you. And as you can see from these, this is just a comparison of the trials. Patients were relatively young, around 60 years, very male dominated, probably reflecting the underlying etiology of coronary artery disease, which relates to some lifestyle factors, and probably at that era, particularly smoking. Tended to have a reduced ejection fraction, and different presentations with different types of ventricular arrhythmia. I think what is interesting in these is the actual background medical therapy, because in that era, there wasn't many of the contemporary medications for heart failure or cardiomyopathy available. So in AVID, only 40% of patients who received an ICD also had a beta blocker, and 68%, for example, had an ACE inhibitor. And none of the contemporary therapies were represented, being an MRA or sacubitril/valsartan or an SGLT2 inhibitor. So you do wonder, actually, the more you think about it, how applicable this is to current practice. Based on those three trials, there was a meta-analysis of secondary prevention ICDs by Stuart Connolly, published in 2000. this is a hugely cited meta-analysis, and overall mortality was significantly reduced with an ICD compared to amiodarone. That's the left panel. And that was largely driven by a reduction in arrhythmic deaths, so recurrent VT-VF on the right-hand panel. As I was reading this last week, one thing really struck me, which was that meta-analysis had a pre-specified subgroup analysis divided by an ejection fraction, so your systolic, left ventricular systolic function, of greater than or less than 35%. And you can see that in patients who have preserved left ventricular ejection fraction, or not even preserved, but even mild to moderately reduced, there was actually no survival benefit to an ICD relative to amiodarone on the left panel. So all of the benefit was confined to the patients who had quite severe heart failure, which is something, we discuss patients like this in rounds every single week. Every patient who gets an ICD gets discussed before implant in the EP group. And when I reflect on this, I think we often err on the side of caution. If we were to revisit the evidence, we'd see that the benefits are maybe not as great as we think. And this, remember, is even in the era of non-contemporary medical therapy. So it does make you question whether some of those studies should be revisited. But based on those trials, this is the guidelines for secondary prevention ICDs. Survivors of cardiac arrest, patients with structural heart disease and a spontaneous VT, patients with syncope that's felt to be sustained VT, and then some sort of more borderline indications. Important to note that class 3, which is i.e. not to be implanted, does include patients who aren't expected to survive for at least a year, or to have incessant ventricular arrhythmia, or something that means it's unlikely to actually convey a survival benefit. And one of the drivers for this project was, as we reviewed literature, we noted that on the right-hand column here, this is the uptake or utilization of secondary prevention ICD. So these are patients who've had a cardiac arrest. If you take all comers, how many of them go on to get an ICD? And firstly, much of this evidence is actually very old. So these are the publication dates on the left, and then the actual years. You can see that the majority is sort of last, pre-2000 or early 2000s. And the uptake is quite variable, but it can be as low as 7–15%, excluding one which only Caputo, which only included patients who'd sort of survived and had an ICD. So discounting that one, until a very recent study from Toronto at 57%, Ho in 2017, the highest uptake was 30%, which suggests there is a potential gap in care, i.e. 70–85% of patients not getting a defibrillator. But the question is, how appropriate is it? And you'll see I've added a column here, which is, was reversible causes excluded? Because if you have a reversible cause, you probably don't need an ICD. And the answer in almost all of those studies was no. There was no way to actually characterize or exclude a reversible cause in those cohorts. So I think genuine appropriate use is really a large unknown. So a brief background, the Resuscitation Outcomes Consortium, or ROC as I'll call it, is a network in North America consisting of a number of large sites who have prospectively recorded very, very granular information about patients presenting with an out-of-hospital cardiac arrest. And there's been a large number of landmark clinical trials come out of that network. Chris Fordyce, when he started with the division under the mentorship of Karen, has sort of led development of a quite a complex linked registry. And I've been very fortunate to be involved with this along with Brian and Mark DL, one of my other EP colleagues. But essentially we have ROC, which captures the pre-hospital phase and some intra-hospital characteristics, and that's a point I'll come back to. And then that is now linked with the population administrative data sets, a population data BC, so the discharge abstract database, NACARS for emergency admissions is going to be in the process of being linked very, very soon, hopefully this month. MSP billing, we've linked to the what used to be called Approach and is now called HEART-IS, which is the Cardiac Services BC registry of all procedures, which does give a very strong advantage in terms of capturing procedures, defibrillators, angiography, PCI, so stenting and bypass surgery, and then also PharmaNet as well, which allows us to look at medications before the index event and then after the event as well. And Chris and I were successful in getting a funding award from the CCS to examine a number of items. So this linked registry, we're in the process of submitting the first analysis, which is looking at the long-term outcomes of patients who survived the out-of-hospital cardiac arrest. And then as part of the CCS award, we have numbers 3, 4, and 5 here. Number 3 is looking at healthcare encounters, which we're terming sentinel events prior to a cardiac arrest, to see if we can identify in that pyramid in the larger population if there's factors which can predict subsequent arrest. And then this project, which we'll discuss, and then the 5th is looking at the long-term outcomes in patients with reversible causes. So this is our cohort flowchart, and this is a very typical of an out-of-hospital cardiac arrest registries. So it's not quite the same as when you look at say a trial recruitment flowchart, which seems to suggest that there's some sort of bias if you end up with a much smaller number at the bottom compared to the top. But the sad facts of out-of-hospital cardiac arrest is you start with a very large number of patients. So we've got 23,000 out-of-hospital cardiac arrests between 2009 and 2016. And this is for the 4 large metropolitan areas of BC. So it covers about 75% of the BC general population. We are looking into this, but there was about 5,000 patients couldn't be linked to those external data sets, and that's largely in patients who didn't survive to hospital admission. So information on those patients becomes more patchy. So although there's a significant number not linked, that doesn't necessarily invalidate the findings of our specific analysis, because we are very much focused on hospital survivors. So excluding those patients, the remainder were linked to the data sets. We have EMS treated, so those are the patients who actually survived to hospital. You can see that 7.5 of those 10,000, 7.5 actually died, so 75% died pre-hospital. 3,200 were admitted. Another 2,000 of those patients died in hospital. So from that 23,000 patients with cardiac arrest, the hospital survivors for this analysis is 1,325. And that sort of ratio and exclusions as you go along is very typical of a cardiac arrest registry. So this is really important, and we've spent a lot of time discussing this, with Mei Zhao and other members of the team, and myself and Chris and Mark DL, about how we try and understand ICD decision-making and boil it down to data variables, but we can decide if a patient is eligible or not. So first of all, based on those guidelines and the trials, they have to have a shockable rhythm as opposed to a non-shockable rhythm. So a defibrillator, if you had a cardiac arrest because of a non-shockable rhythm, the defibrillator will not help you in future, or is very unlikely to help you in future. Is it reversible or non-reversible? Is it ischemic or non-ischemic, meaning is it related to coronary disease or not? And then other important variables as well, this is the residual substrate. So if I take a case, somebody's admitted to hospital, they have some coronary disease, it's stented, but they have residual heart failure or reduced ejection fraction. Does that patient require an ICD, or was the actual cause treated? And then is there a contraindication to implants? Which are they expected to survive a year? Did they have, for example, a good neurological recovery? So you can see it's a complex area to define eligibility in. In terms of defining reversibility, we do have several advantages in this data set compared to other publications. So the first is not only we can define acute ischemia, which would be a STEMI, an ST elevation MI, and we can, because we have the cardiac services registry with coronary anatomy, we can also look at the severity of coronary disease, and we can look at if they were revascularized. So was there a critical lesion that was treated appropriately? And also within the cardiac services registry, Heart-IS, there is a variable for sort of tick box, which was complete revascularization attained? So not just looking at the coronary anatomy on a diagram or figures that come out from that registry, but did the operator, who's the person probably best suited to make that judgment call, did the operator feel that all of the vessels were revascularized appropriately? So I think that's a major strength. We do have from the cardiac arrest registry and from the discharge abstract database some information on electrolyte disturbance, although I would say we felt that was going to be stronger than it was in the arrest registry, so we've relied mainly on the coding of a hospital episode. We have the PharmaNet information for drugs which may cause ventricular arrhythmia, so some antiarrhythmic medications are also paradoxically pro-arrhythmic, and there's certain medications have a high risk of QT prolongation, which is one of those causes I showed you at the very first diagram at the top of the pyramid. QT prolongation can predispose to ventricular arrhythmia, and Ricky Turgeon, who I saw on the call, very helpfully supplied us with a list of a sort of ranking system for severity of QT prolonging interactions. And then we also have in the ROC registry the various other causes like sepsis and pulmonary embolus, drowning, electrocution, whatever it might be. So we can characterize the etiology, the presenting rhythm, and reversibility, I would say, as well, if not better, than most of the literature to date. So this is how our cohort broke down, and one of the real challenges we have had in this project, and we've gone backwards and forwards a lot, is there's so many overlapping subgroups, and you saw that on the clinical decision making. It's like a Venn diagram with maybe 4 or 5 key components, and which way you order those, essentially the column headers and how they divide up, really does influence how the numbers look in terms of uptake. So we've settled on, and I think this is, Major, I'll be happy to know, this is probably a final decision and the correct one, we think, that the shockable versus non-shockable rhythm is by far our most robust variable. That's based on the rhythm strips and recorded in the ROC registry and goes through a series of checks. So that's very robust. After that, we have the reversibility, and because a lot of reversibility is driven by coronary disease and revascularization, and that's a unique strength of the data set, then we felt that this, although there's obviously, it's not perfect, this was also a very strong indicator. And then within the reversible and non-reversible, we divided up into ischemia and non-ischemic causes. And ischemia is relatively straightforward to define because we have coronary anatomy in a large proportion of patients. The non-ischemic is definitely a little more challenging. It becomes almost a diagnosis of exclusion. So if you don't have coronary events, some of those non-ischemics are definitely electrolytes and other things we can identify, but others aren't quite so much. But if we look at the breakdown here, so we'll get the non-shockable out of the way first, I think, because the non-shockable, you wouldn't expect to receive an ICD, and you can see in the couple of green numbers highlighted there that the number of ICDs implanted is very low in those patients. So let's discount those. And then we can move on to the shockable, so the left kind of grouping, and that roughly evenly splits into reversible and non-reversible. And then the reversible is largely ischemic, but wasn't actually that many reversible non-ischemic causes, probably about 10%, which actually, in a lot of studies, it's about 80% of the etiology is generally coronary related. And you can see here that in reversible ischemia, the use of an ICD is actually relatively low, about 18.5%. And in reversible for non-ischemia, the numbers are much smaller, but again, it's quite low. And then the highest uptake is in the shockable, non-reversible group, which is exactly as you would expect, with an ICD rate in the non-reversible ischemia of 53.7% and in the non-reversible non-ischemia of 59%. So this is starting to get at this idea of eligibility. So we have somewhere in the region of 55 to 60% of eligible people, non-reversible, receiving an ICD. And if I was to show you this in a slightly more pleasant graphical way, you can see that we implant about a third of all survivors receive an ICD. That's very low in the non-shockable overall, 7%. Shockable reversible cause is about 20%. And of course, that could be because they have a reversible cause, but then something else for their presentation, but maybe they have another risk factor for future ventricular arrhythmia, such as heart failure. And then our 55.6% of a non-reversible shockable rhythms. We looked at whether patients receive these in hospital versus delayed to see if we needed to do a stratifier analysis in some way. The vast majority of patients receive their ICD in hospital, with a smaller number going on post-hospitalization up to 1 year to receive an ICD. So we haven't really sort of subgrouped these out anymore simply because the numbers are too small. This is our trends over time. You can see that in the top we have a shockable non-reversible, so what you'd call appropriate. And the rate there is about 50 to 60%. And in the shockable reversible, that's much lower. And then the black line is overall. There's no significant increase over time in those trends. How does that compare? Like I say, the only really appropriate comparator is this study from Toronto, and we actually have quite similar results there. You can see the likely eligible in their orange line is very similar to our green line, although they did observe an increase over time over a roughly similar period. So they started much lower. They started at 45 and went up to just over 60, whereas we started around that level and stayed that level. To look through, there's a lot of baseline characteristics, and I've just highlighted probably the most important things, so we'll focus on the right-hand side, which is the non-reversible, i.e. eligible patients, and look at the patients who received an ICD in hospital versus not an ICD. And things are, the patients who received an ICD have more heart failure and a slightly higher prevalence of some comorbidities. But I think probably the excess in heart failure is the thing that partly drives the ICD uptake. What's also interesting is in those patients who don't receive an ICD is that they tend to have a much higher incidence of presenting with an acute infarct, and again, a lower incidence of presenting with heart failure. One of the things that is very interesting, I don't have an explanation for this, but it has come out as a predictor in one other study, is that if your arrest was witnessed by a bystander, then you have quite a notable increased chance of receiving an ICD if you survive to discharge. So whether that is there's something about their social circumstances or their home circumstances after the arrest, or something about the description of their quality of life beforehand, it's not entirely clear. And there's a couple of features as well about this non-reversible group which are notable, and one in particular which we need to revisit in this analysis is their discharge status. So we can see that patients who don't receive an ICD have a higher prevalence of going to long-term care, so 7%, and also being discharged home with support, 6%. This is the bottom right. But only 80% of them were discharged home without any form of support, as opposed to those who received an ICD, that was 93%. And in the shockable and reversible, that was 98 and 87%. So I suspect part of a reason that the patients who aren't receiving an ICD are not getting an ICD is the fact that they have neurological impairment and need for home care or long-term care, which we haven't captured as yet. So I think we need to revisit our variables. This is just a summary of the functional outcomes from the cohort overall from Chris's main paper. You can see that 76% of people have a good functional outcome, 14% of discharge were home services, and then the long-term care is a much smaller proportion. So if I was flicking back to the baseline characteristics there, you can see that the no ICDs actually fall within the upper segments there of that pie chart. So this is our predictors of implant in patients with an out-of-hospital cardiac arrest with a shockable rhythm. And if we concentrate on the right-hand side, and I've highlighted in red the multivariable independent predictors, you can see that there is increased likelihood of getting an ICD if you've had prior bypass surgery, which makes sense. You've got presumably coronary artery disease and scar. If you have increased incidence of heart failure, and if it was witnessed, again, so coming back to that idea that something about having a bystander witnessed event seems to increase your chances. Now, there's an interesting interaction between reversible and non-reversibility here, which is to say that if you have a reversible cause versus a non-reversible cause, if you have heart failure, then the reversibility doesn't make any difference as to whether you get an ICD. And that does make an inherent sense as well. So if this patient has heart failure and a reduced ejection fraction, they'll probably receive an ICD based on that. Whereas if you have reversibility, if you don't have heart failure and you have reversibility, you're much less likely to receive an ICD. So the odds ratio there is 0.15. And that's very similar. So predictors of not receiving an ICD are reversibility and a non-ischemic etiology, and whether you present with an index MI. So you can see that these concepts of reversibility and ischemia and presenting MI all seem to overlap. A couple of just final comments on the predictors of receiving an ICD is that if we look at their medications prior to admission, so that's the bottom, if you're on a statin or you were receiving warfarin, they're strong predictors of receiving an ICD after a cardiac arrest. And that is a puzzling finding. And, you know, some of the things the questions as I've looked at this prediction model and thought about things are, should we, and we can return to these, should we be having a prediction model as we have done for patients with a shockable rhythm versus the entire cohort? And if we were just looking at the patients with a shockable rhythm, should we be doing all of the shockables versus just those with a non-reversible? I.e., should we be looking at predictors just within the group that we feel would be eligible? That would be non-reversible, because that would partly take out the reversibility interaction that we're seeing for some of the variables. Is there some sort of effectively collinearity, because we have reversibility and ischemia and myocardial infarction, and how do we deal with those within a model? Should and how should medications be introduced? You know, there's always some selection process in medications. It's not an inherent property of a patient necessarily, and different people have different views on whether medications should be included in models, and what would be the explanation for a statin or a warfarin making you more likely to receive a defibrillator. And then finally, are we missing some variables? Like, do we need to go back to the ROC registry and look at neurological status, or should we be trying to potentially force into the model things which are of borderline significance? So that might be some comorbidities, or it might be the discharge functional status. So that's, are you likely to receive an ICD? This is your outcomes if you do receive an ICD. So this is, we pre-specified a composite of death or recurrent cardiac arrest recorded in ROC, or VT or VF hospitalization. And you can see that overall, there is no survival benefit associated with an ICD. And it's an association, to be clear, because this is observational data. However, when we split that into reversible and non-reversible, we see, and this is, you need to be careful here because the colors swap over. So if you, in the reversible patients, so people who we think probably shouldn't get an ICD, those that get an ICD actually do slightly worse. They're the red, and they have a worse survival for the primary endpoint. Whereas the non-reversible, so the patients who we think should get an ICD, you can see that those patients, the ICD recipients in the red, do significantly better than the green line, the patients who don't receive an ICD. So in a way, this, surprisingly, for observational data, seems to completely validate that, you know, the guidelines and the trial evidence that ICDs convey no benefit in reversible causes and do have an associated survival benefit in non-reversible causes. And we looked at, as a component of that, all-cause mortality, so just death as opposed to the composite of death, arrest, and VFVT. And the trend was exactly the same, partly because the numbers are, you know, in large part driven by death, but very almost identical trends. And the final part of our analysis is we have predictors of survival of the composite endpoint, so death, arrest, VFVT. Increasing age is an independent predictor. Heart failure, as you would expect, is an independent predictor. Prior bypass surgery, comorbidities like kidney disease and cancer. And then there's another interaction between, this interaction that we see between reversibility and ICD implants. So if you receive an ICD and you have a reversible cause, in the multivariable model, there is no impact on survival. In the non-reversible cohort, the very bottom line here, ICDs are associated independently after adjustment with better outcomes. So to place this in some perspective, there was a recent publication from a Pittsburgh group, which looks at a post-cardiac arrest service spanning 7 hospitals with nearly 700 patients. And this is really interesting because they looked at the association, so these are adjusted, multivariable adjusted associations with outcomes for angiography and ICDs. And you can see that angiography and ICDs are associated with reduced all-cause mortality. But angiography was not associated with reduced cardiac death, although ICDs were. But most importantly, both of those procedures were strongly associated with non-cardiac death, which is completely implausible. You know, an ICD is, or having coronary angiography is not going to reduce your risk of non-cardiac death by 75%. So the conclusion from this is that although you are performing a multivariable adjustment in observational data, you are almost certainly not adjusting sufficiently or not accounting for the decision-making that goes on in deciding on a procedure. I.e., there's large selection bias, so procedures are performed on patients who have a better anticipated prognosis. And so one of the final questions to discuss is, you know, what methods can we use to address that? Should we be looking at propensity scores or inverse probability of treatment weighting? Should we then be combining that with some like a survival model in the sort of so-called doubly robust estimators? So in quick summary, the strengths, we have a large prospective cohort, it's contemporary, we have rhythm very robustly defined, we have the causes of arrest defined, we span the complete patient journey, we have the medications, we have coronary anatomy, we have complete revascularization, we don't have ejection fraction, we don't have ICD follow-up in terms of shocks, we need to look into neurological status more, I think. We don't have cause-specific death. Conclusions, the more you dig into this, the more you think, what really is appropriate use of a defibrillator? Is a complex clinical decision actually definable? How would we build a system to surveil that optimally for quality improvement? Do we need a dedicated post-cardiac arrest service possibly? These are all the sort of questions that are running through my mind as I've worked through this. And I will open up to, hopefully, thoughts and comments.